Bismillahirrahmanirrahim. Nahamdahu wa nusalli ala rasulihil kareem. Amma ba'd. Quality and patient safety. This is not the new concept for the world, but yes, for the Pakistan, it's an emerging concept. How quality and patient safety came into existence, what is the role of DQM, and how it evolved during the past 50 to 60 years, and the incorporation of quality and patient safety in Pakistan. Today, all this we are going to discuss. Today's session is specifically for the quality and patient safety practitioners and those who want to practice quality as a profession. So, in this regards, we are going to discuss evolution. First, we are going to discuss the evolution of quality in healthcare in Pakistan, and it's my honor to introduce Dr. Mairaj, which is our first speaker. And Dr. Shah is presently working in AKUH Hospital as the Chief Operating Officer, Secondary Hospitals, Pakistan. He is associated with AKU since 1992 under various leadership and management positions, including Director Operation and Medical Director. Dr. Shah is the certified quality professional from QPSP and certified quality manager from ASQ, certified professional healthcare quality from USA as well. And he is an international physician surveyor for the Joint Commission International Accreditation of USA. He served as past Vice Chancellor and Chairman of Quality Productivity of Society of Pakistan. So first we are going to listen Dr. Mirasha regarding the evolution of healthcare quality in Pakistan.
Assalamu alaikum. Good morning, afternoon, and evening as per the time zones of the audience. I welcome you all to this presentation on evolution of healthcare quality in Pakistan. And before I do that, I want to congratulate the Indus Hospital Health Network for organizing ICON 2022 with the theme of Beyond the Call of Duty. So colleagues, I'm Dr. Syed Mirajuddin Shah, simply Mairaj. I'm working as the Chief Operating Officer for the 4 secondary hospitals of the Aga Khan University Hospital here in Karachi. So the topic of my presentation is evolution of healthcare quality in Pakistan. So I will start with my presentation. Here is my disclosure statement. I don't have any conflicts of interest. In the next 20 minutes, the information that I'm going to deliver you, my session's objectives for that information is by the end of this session, we should be able to learn how quality and healthcare quality evolved as a discipline internationally and in Pakistan. Understand the milestones of quality and patient safety initiatives in Pakistan. And finally, know the Aga Khan University Hospital's quality journey. So that will bring us in alignment with the evolution of healthcare quality in Pakistan. So let's start with the presentation. And here is the evolution of quality from the floors of the manufacturing industry to the patient's bedside in the healthcare sector. Simply, I don't want to take you all into the details of the evolution of the international canvas of quality, but it is important to know that the philosophy of quality was shaped by these quality gurus. The concept of variation in the control charts came from Dr. Walter Shivart. One of his students, Dr. Edward Deming, is very famous for the 14 points and the Pdca cycle that we use these days in healthcare as the Pdsa cycle. Dr. J.M. Joran, famous for the quality planning, quality control, and quality improvement as the quality trilogy. Dr. Kaoru Ishikawa, the father of Japanese quality control, who also introduced to us the fishbone or the Ishikawa and the cause and effect diagram. Dr. Armand Feigenbaum, his 4 absolutes of quality, and the Bill Crosby, who wrote the book by the name Quality is Free. What he meant was what is not free is the cost of poor quality that is not free. Similarly, the evolution of healthcare quality started from the very, very golden period and goes back to many centuries. Al-Razi, the famous Muslim scientist and the medical professional, you can say, is very famous for um, early medicine that gave birth to many concepts of healthcare. Then Hippocrates, the Greek physician who was given the title of father of medicine. Even today, any medical graduate around the world, when graduates out of the medical school, takes the oath on the name of the Hippocrates. Florence Nightingale, the lady with the lamp, who was the first lady to introduce the concept of healthcare statistics and healthcare data management during the Crimean War, when she used to visit with the lamp at the night and used to maintain a register to count the types of injuries, number of injuries, and nature of injuries of the injured soldiers. Dr. Ernest Codman was an orthopedic surgeon based in Boston. His work finally capitalized to what we know today, the Joint Commission, previously JACO, today's Joint Commission and the Joint Commission International. Dr. Evedis Donabedian, a board-certified internal medicine physician in 1960s, introduced the concept of structures, processes, and outcome. Even today, I consider that model as a very, very practical model to understand the healthcare quality concepts. Today's world, Dr. Donald Berwick, professor of pediatrics and ex-CEO and the president of the Healthcare Institute, IHI, gave many new concepts to the healthcare quality board. Now, if we summarize the four eras of the quality starting from 1860s, from the Crimean War, Nightingale, Ernest Codman, and formation of the American College of Surgeons. 1950s to 1960s, the era number two was of the Donabedian and the JACO. From 1970s to 80s, Dr. Donald Berwick with the IHI, Paul Battleton, and Brent James presented many great concepts by adopting the Japanese TQM philosophies and concepts into the healthcare. Paul Battleton, what a phrase he said. Every system is perfectly designed for the results it gets. 1990s to 2020s is the state of fourth era, and the main focus during these times were patient-centered care, equity, quality, safety, and technology, especially the healthcare technology, nanotechnology, 3D printing, imaging, digitalization, the big data. That is transforming the way we do business in today's healthcare world. And it's going to tremendously change the healthcare in the next coming 5-10 years. Traditionally, when quality started, evolved from the industrial manufacturing floors and the defense systems during the World War I and after World War II, the time of the Industrial Revolution, with the aim of the mass productivity, the quality started with only inspection. That was a very costly activity. Then came a time of quality control. And then one step ahead, quality assurance, the next step, quality improvement, and then the final step. Even today, we are partially in this step, total quality management. And these days, we are talking about excellence. Coming to the evolution of quality in Pakistan. So quality in general, if we talk about quality and what is not quality. So most simply, quality is doing the right things right. Anything that is fit for use and is considered by the market as fit for use is quality. Quality is conformance to requirements. Quality is zero defects. Now, these are all definitions from these quality gurus about general quality. So Pakistan came into existence in 1947, and right from those days, at the end of the 1940s, 50s, TQM concepts were there because these were being practiced in the manufacturing, in the defense sector, in the textile sectors, in the agri sector. So these TQM concepts were there. Big factories, industrial sector were practicing many components in a fragmented way. 1980s, the world was taken over by the European and initially the British standards, the BSI standards, and then later on the European ISO 9001 quality management system families of standards. So it really got very good attention because it became a necessary requirement for doing business in Europe. And many companies, and even in Pakistan, starting from the manufacturing and the industries, they started going for ISO 9001 certification. The initial standard, the first standards that came were in 1987. I think then it was 1994, then 1999 or 2000 something, and then finally 2015. So this was a time of the quality management system and the ISO certification with a focus on a documented quality management system, especially if companies were considering their business as a set of processes that uses certain inputs to produce outputs. Then from the year 2000 and onwards, generally in quality, the quality world was taken over by statistical process control, and then by Six Sigma, and then by Lean Six Sigma. Evolution of healthcare quality and patient safety in Pakistan is not a very long phenomena. We can say 2 to 3 decades old phenomena. Quality was the last to be pursued by the healthcare sector and the education sectors all around the world. So in 1980s, again, healthcare started. Few organizations in Pakistan started learning the basic TQM concepts, especially the CQI methodology by the Juran Institute, Inc. And amongst the pioneers, I'm honored to be associated with the Aga Khan University Hospital. The Aga Khan University Hospital started pioneering those concepts in 1985 and 1986 when the hospital came into existence. 1990s ISO 9001 framework was there, and some healthcare organizations started pursuing towards ISO 9000. In addition to the direct healthcare providers, some private organizations, some government organizations, and some NGOs, they also came, joined hands in hands. For example, the Pakistan Institute of Quality Control that came into existence in 1991 played a very vital role in providing awareness, education, and training on different subjects and matters of quality in general. And in 1996, the Pakistan Standards and Quality Control Authority was established, and they came up with the mandate of creating standards for the different product and service sectors of Pakistan, and they did a great job by creating those standards. Finally, they were also able to launch the primary care standards and the hospital standards for the Pakistan as well. Then in 1998, the Ministry of Science and Technology presented this Pakistan National Accreditation Council, and the main mandate of Pakistan National Accreditation Council was to come up with the accreditation of the certifying bodies and the measuring labs. So they came up with different sets of standards. Still, they are working on certifying in healthcare the clinical laboratories on ISO 15189 maybe. And then came in 2000s the JACO, the Joint Commission in US. They, for the very first time in 1999, they released the international chapters of standards to be used by the international community outside US by the name of JCIA. So JCIA is a subsidiary of the Joint Commission, previously known as JACO. Since then, many healthcare organizations around the world and few organizations in Pakistan, they started preparing for JCIA, and the Aga Khan University Hospital has the honor of being the first hospital in Pakistan to be accredited to Joint Commission International. So we started our preparations in 2000, and we got the first accreditation in 2006. And then we were also first when the Joint Commission added 2 specific chapters for those healthcare organizations that are classified as academic medical centers. So we were the first in Pakistan to get accreditation, to be accredited as the first academic medical center in Pakistan to be accredited by the Joint Commission. Then in 2009, we developed a chapter, healthcare chapter of the Quality and Productivity Society of Pakistan. Now, this chapter really engaged many healthcare organizations from primary, secondary, and tertiary care in Karachi and outside Karachi. At that time, we developed the understanding, the mandate to improve the quality and patient safety standards of the healthcare in Pakistan. In 2016, RIFA Institute of Healthcare Quality and Safety was established, and they started doing a good job. And then finally in 2017, 2015, from 2015, Provincial Healthcare Commission Acts and the Healthcare Commission Minimal Service Delivery Standards were launched with a procedure to issue licenses to the healthcare organizations who conform to these minimal set of standards. Now coming to the core activities during these times from 1980s to 90s to 2000 to today, where we are right now in 2020s, healthcare quality and patient safety activities in Pakistan went through different incremental steps. Some hospitals, some organizations did it in very organized, systematic way and rose to the level of third-party certifications and accreditations. And some organizations went without certifications and accreditations, and they use those models for the self-improvement purposes. So traditionally in Pakistan, healthcare quality, especially in teaching hospitals, both in public and private sector, mortality and the morbidity reviews were a good tool to learn from the mistakes and to identify opportunities for improvement. Then gradually organizations learned about the importance of patients as customers, as clients, and they started establishing process to listen to the customers, to listen to the clients, and giving them an opportunity if someone is not satisfied and want to lodge a complaint, the process of patient's complaint handling. And then, collecting the data on the patient complaints, analyzing the data and converting it into useful information provided many opportunities to those institutions who are using this data as a quality tool for identifying opportunities for improvement. Then organizations went beyond from a reactive to a more proactive way, started launching surveys for the patient or the client satisfaction. Then organizations started focusing on medical record documentation, because there is a very famous saying that care not documented is care not given. So in healthcare, the most important record of information is the patient's information that is written in the patient's medical records or charts. So medical record documentation became a focus, and many hospitals started some ways and means of establishing a paper-based medical record system. Few organizations went beyond this, and they came up with a electronic health record. And to mention the names, Shaukat Khanum Memorial Hospital and the Cancer Research Center and the Indus hospitals are two examples where they started their journeys with the electronic health records. Congratulations to both the institutions for doing that. Then the organization started learning on measuring quality, because institutions in Pakistan, healthcare quality professionals, when they were receiving education and training locally and abroad as well, they started learning that without measuring, there is no way you can evaluate the quality of healthcare services. Then came the concept of Donabedian structure, process, and outcomes, and obviously the structural measures, the process measures, and the outcome measures. So came the concept of KPIs, quality indicators and measures. After this, the quality audits started. So organizations started learning about doing the quality audits based on certain criteria, based on certain standards. Then from the NHS in England came a very famous model of medical or clinical audit. And it became a very good tool to improve the clinical quality or the medical quality by performing clinical audits on defined focused subjects or topics. Then the world started learning from the West that in order to have a better quality, you must learn about the credentialing and privileging programs for the medical staff, for the nurses, and for the allied staff. So by doing credentialing, proper credentialing and privileging, you are making sure that you are giving your patients in the safe hands of the physicians and surgeons who are going to treat them. And there is a monitoring process for the performance of these physicians and surgeons on the privileges that they have been granted, and some data collection process on the performance, and that becomes the, in today's world, the concept of ongoing professional practice evaluation. Then the healthcare organizations started learning from the manufacturing floors, from the quality management systems, ISO 9000, about the importance of documentation, about the importance of writing standard policies, procedures, and protocols, so that the care and the caring processes becomes more standardized. Policy tells you what to do, procedures tells you how to do. In this way, the concept of clinical practice guidelines, evidence-based medicine, clinical protocols came, and that really helped. So different hospitals, different healthcare organizations in Pakistan were at different levels on these activities. Some were maturing at the entries which are at the bottom of this list. Some were just stepping on the first few steps, and some were somewhere in the middle. Then came the trend of ISO 9001 certifications. So we were also first from the Aga Khan University Hospital to be the first in healthcare and the tertiary care hospitals to get the ISO 9000 certification. And then, of course, the healthcare accreditations came. Joint Commission, International Accreditation became the gold seal. And we were so glad and happy that following the footsteps, by helping some other organizations in Pakistan, and that is one of the mandate of the Aga Khan University, to be the healthcare leaders and to help others around us within the country and in the region, by sharing resources in terms of education, health, and research, as well as excellence. So other institutions, they also came up in the line, and I would like to name four organizations. I have just shortlisted these four because there is a third-party endorsement and the gold seal of Joint Commission International to all these four big healthcare systems in Pakistan. To begin with, the first institution was the Aga Khan University Hospital, who got JCI accreditation in 2006. This was followed by Shifa International 6 years ago, Shaukat Khanum 3 years ago, and then Rahman Medical Institute is not yet JCI accredited, but I think Rahman Medical Institute team is doing a great job in terms of preparing infrastructure for their readiness for the Joint Commission and providing very rigorous education and training programs on different aspects of quality. Similarly, Shifa is doing a great job in producing quality professionals. And it's a pleasure to know for all of us that these two institutions have produced several physicians, nurses, and other allied health staff members to acquire the international credentials like Certified Professional in Healthcare Quality, CPHQ, as well as American Board of Quality Assurance and Healthcare Utilization Physicians credentials. So congratulations to all the three organizations for providing that and producing more people on the quality trainings. And of course, the mandate of Aga Khan University, Aga Khan is very rigorous in giving trainings. Our CQI facilitation training has produced more than 2,500 medical, nursing, and allied health staff members. We have certified professionals in healthcare quality, and we do various in-house and ex-house training programs in the relevant areas of quality and patient safety. Last but not least, I'll just give you a very brief insight with an analogy. And the analogy is comparing it with the climbing the summit of the world's second highest peak, K2, Again, we are blessed in Pakistan to have that second highest peak in our country, K2. And this is a 8,000er plus, and to climb K2 is not a joke. So I'm just trying to correlate that quality is just like climbing a very big, very high summit, and it's not easy. So you go on phases. You start from the base camp, then you go to the camp 1, camp 2, camp 3, and then you aim for the summit. So the Aga Khan University Hospital started its operations in 1985. You can see my cursor here. And just after the hospital opening, next year we started the basic quality assurance activities based on Joran's CQI methodologies. We organized the Aga Khan University organized an excellent 3 days training in Nairobi. And guess what? I mean, the speaker in that conference at that time in 86 was Dr. Donald Berwick. Dr. Donald Berwick from US was invited there. And the theme of the conference was creating stress for change. How you can create stress for change, because without creating stress for change, change will not happen. If change will not happen, improvements will not happen. So we trained many senior leaders in that. And when they came back, they started the CQI facilitation tools training program. Then in 2000, we got ISO 9000 to 1994 certification. In 2003, we got ISO 9001 2000. In 2006, we got first JCI accreditation. And at that time, the standards, third edition of the standards were in place. Then in 2009, we got HACCP, food safety accreditation, which is known ISO 22000, 2005. Then in 2016, our whole clinical laboratory program got College of American Pathologists accreditation, which is itself a gold seal and a hallmark for the quality standards in the diagnostics. And now recently in the September 2021, we went through successfully our 5th JCIA reaccreditation on the 7th edition. And this year in 2022, our radiology programs are preparing for accreditation from the American College of Radiology, and our physical therapy and rehab program is preparing for the International CARF accreditation. And the journey will keep on going. The summit is still quite far, and we have to keep on moving. In conclusion, dear colleagues, I just want to emphasize 3 points. In the context of evolution of healthcare quality in Pakistan, I didn't talk about the status of healthcare quality in Pakistan. All I know, all you know is Pakistan is among those countries in the third world which are really struggling with the healthcare infrastructure. We are a country who is spending 2.5% of the GDP, and there are many challenges. Although the ranking is rising gradually and very slowly, but it's a long way we have to go. So 4 points that I want to highlight as a conclusion. Healthcare quality and patient safety are integral components of healthcare structures, processes, and outcomes. If you want to improve your organization's structures, processes, outcomes, you cannot separate out quality and safety from your day-to-day operations. Whether you are in primary care, whether you are in secondary care level, or whether you are at tertiary care level, whether you are in public sector, or whether you are in private sector. So remember that. The concepts are still at the early stages of the evolution in Pakistan, but it's moving. And I'm very optimistic that with time, we are going to go to the next level of excellence. And achieving a level of excellence that was never achieved before is one of the definition of quality improvement. And I'm happy to see that overall the healthcare organizations are moving in that direction. There is a need to involve and engage both the public and private healthcare sectors in the understanding and implementation for the quality and patient safety standards in its true spirit. Trying to bring out change from inside out, not from outside in. Not doing it just because we want to get a license. Not doing it just because we want to have a certificate or an accreditation award. but we want to do it because we are seriously interested in improving the quality and safety standards for our patients, for their families, for our staff. And we are really interested in improving, taking our organizations to the next level of excellence. And finally, and very important, the national licensing and accrediting bodies must play a vital role in the promotion, implementation, and compliance to these standards. It will really count. That would be a very vital role. So, last but not least, hats off and my sincere thanks to all the frontline and the backline healthcare teams all around the world for going beyond the call of duty during this COVID-19 pandemic, which is still going. Let's learn how to live with it. I salute you all. I pray for your safety, for your success, and for your prosperity. Love you all of the healthcare providers. Thank you very much.
Thank you very much, Dr. Mairaj. It was
If you
such
have any questions, we will do that in the Q&A sessions.
Thank you very much, Dr. Mairaj. It was such a interesting topic. Basically, the evolution of healthcare quality. This concept is a very new concept, and this is very important to know. This is very important to know for the juniors, for the newcomers who want to practice patient safety and quality as a profession. So I think it's a time that we should have to move, and we should have to have a joint collaboration between the public and private partnership for the improvement of the patient care or the patient-centered care. And this is the time we have to join together for taking the quality and patient safety journey in Pakistan towards the next level. So with this word, thank you very much, Dr. Mirasha, again. So our second speaker is Dr. Lubna Mushtaque. She is going to talk about performance indicator as a success of QI program, because we know after the evaluation, this is the second step to measure your performance. So let's hear from Dr. Lubna.
Bismillahirrahmanirrahim. Nahmaduhu wa nusalli ala rasulihil kareem, amma ba'd. Today we are going to discuss performance indicator as a success of quality improvement program. So before starting the actual topic, I would like to take you towards the objective of today's talk, which is we are going to define the relationship between the performance monitoring and quality improvement, and then identify the strategies for enhancing the performance monitoring systems. And then we will discuss about how to explore the opportunities to use these performance data for a quality improvement processes. So what performance indicator is? Before starting the performance indicator, I would like to discuss about what quality is, because at the end of the session, I'm going to connect the performance indicator as a success of the quality improvement program, a quality improvement project. So what quality is? As a starter, quality is doing the right thing at the right time, right from the first time. So here the question arises, how do we know that we are doing the right things? So to answer this question, we have several parameters set by the national, international, and organizational at organizational level to know on which parameters they are going to work on. Like, for example, how I can know that I am doing the correct thing. My organization sets certain standards. I have to comply on these standards, and the standards, guideline, policy, procedure, protocol, these are the parameters which tells me that I'm doing the right things. So the right thing must be on the evidence base. Then the second question is, what is performance indicator? So performance indicator or key performance indicator, or commonly known as the KPI, is a type of performance measurement, a quantifiable measure of performance over the period of time for a specific objective. So what those objectives are? Objectives are simply target that an organization set out to achieve. In other way around, we can say what organization want to be in the future and what are the target for the organization for the coming 2 to 5 years or the 10 year. We can say the short term and the long term targets. And then the second objective is they are element of the mission. So these objectives are the elements of the mission that have been quantifiable. Quantifiable means we can measure it over the period of time. And in quality, we commonly known as that we cannot improve if we cannot measure it. So these KPIs, the objective of these performance indicators have been quantified and are basis for deciding the appropriate performance measures and indicators for developing the strategy. So in other way around, we can say the one of the objective is a SMART rule. So what SMART is, we all know that SMART is specific, measurable, achievable, relevant, and the time frame. We cannot move without the time frame, without knowing the objective or the definition of the time frame. So first thing first, the specific. What is specific? For example, if you want to measure any performance indicator, your performance of the, like for example, the OT department or OR department of in operation theater, you have to define what exactly you are looking for. What is your target population? You are going to look for the surgical safety checklist. You are going to look for the surgical site infection. You are going to look for the correct patient at the time, correct patient, correct surgical procedure. You are going to look for the identification of a patient. So you have to define the specific area, yeah, specific success you want to measure. So second point is measurable. Measurable means over the period of time, you have to physically track your key performance indicator. Like for example, if you are looking in the operation theater, the compliance of the surgical site checklist, then you have to physically track those checklists over a period of time for the improvement purpose. And after the measurable criteria, you have to define whether this criteria is achievable or no, whether the indicator is achievable or beyond achievable. If the frequency of the checking is not achievable or the objective is not achievable, you cannot take, you have to eliminate those indicators. So relevant, it must be the relevant with the specific measure you are measuring and time frame, as I already mentioned. So the objective of the performance indicator must be on the SMART timelines. So again, how to link the quality improvement versus performance indicators. So quality improvement, I told you the quality doing the right thing right on the first time. And how do we know that we are doing the right thing is from the guidelines stipulated by the organization, by the national standard or the international standard. So according to the Institute of Medicine, they identified quality in healthcare as a direct correlation between the level of improved health services and the desired health outcome of the individuals and the population. And it refers to a continuous and ongoing effort to achieve measurable improvement in the efficiency, effectiveness, performance, accountability, outcome, and other indicators of quality in services or processes which achieve equity and improve the health of the community. So this is according to the Institute of Medicine guidelines. So what to do? So should we go for the process improvement? Should we go for the quality assurance? Should we go for the standards? Which standards, from where these standards will come? Either it will be implementable in our context or not. Quality assurance, which type of the quality assurance, since we are a healthcare industry. So the difference between the quality assurance and quality improvement is again a question mark. And then the role came on the Six Sigma. So what to do and what not, the Six Sigma and the Pdca. So what to do? This picture indicates what exactly we want to do. And there are so many things. How to achieve, how to select the desired subjects. So before this, we have to understand between the concept of the quality assurance and the quality improvement, or CQI, the continuous quality improvement. So quality assurance, since we are in a healthcare industry, so we cannot guarantee anything any specific standards. So quality assurance guarantees quality. We cannot guarantee. We in a healthcare industry can raise its quality. We can continuously improve our quality. So quality assurance is always guaranteed. However, the quality improvement raises the quality. So the quality assurance relies on an inspection, and quality improvement not only relies on the inspection or the audit, but the emphasis on the prevention side as well. So the quality assurance uses a reactive approach after the happening of the incident. However, the continuous quality improvement uses a proactive approach. So the quality assurance look at a compliance of the standard. We at continuous quality improvement not only looking for the compliance of the standard, but we are looking how to improve the processes to meet the certain standard or the stipulated standards. So the quality assurance, another big difference between the quality assurance and continuous quality improvement is quality assurance required a specific fix and relies on individual. However, the quality improvement or continuous quality improvement relies on teamwork and continuous effort, slowly and progressive continuous effort. Quality assurance examines the criteria or requirement. However, in continuous quality improvement programs, they examine the processes or outcome. So we have three things: structure, process, and outcome. So in continuous quality improvement, we are focusing on the processes, not only the structure, but the processes and outcome as well. So in quality assurance, we ask, do we provide good services? And in continuous quality improvement, we ask, how can we provide a better service? So with these words, again, why quality improvement? Why to do this? And what is the need for doing the KPI or the quality improvement? What outcome we will measure through it? So the quality with the quality improvement, we not only streamlining our processes, initially we develop our processes. Or during the streamline of the processes, we came to know that there are certain other features we want to incorporate into the existing process. So this is why we are calling a continuous step, the continuous improvement cycle or processes. So by streamlining the processes and adding a new processes or new step or new outcome, we are trying to reduce the redundancies. In healthcare industry, we have to understand that we cannot eliminate the waste altogether by 100%. If we cannot eliminate, at least we have to reduce the waste. What does it mean by the waste? Waste is not exactly the garbage. The waste is from the processes. The non-value added steps are the waste. Non-value added steps, the extra step, the duplication, the transportation, and the commuting between the transportation of one thing towards a different thing is a waste step. So in continuous quality improvement requires to eliminate or reduce the waste. And so in this way, we can enhance the ability to meet the internal and external customer clients. As we all know that in healthcare industry, we have two types of the client: the internal clients, which are our employees, and external clients, which are our patients. So in this way, by improving our processes, by cut down our cost, by reduced redundancy, by eliminating or reduction of the waste, we are increasing our focus into increase the customer satisfaction with the provided services. And consequently, it will improve our outcomes. So after the quality improvement, here we are going to discuss how to measure the quality improvement. Quality improvement will be measured by monitoring the performance indicators, which is a key element of quality improvement. There are a number of the methods through which the performance indicators can be measured. They are regulatory inspection, the surveys of the consumer experiences, third-party assessment, audits, key performance indicators. So one by one, we will discuss each and every step. So number one is the regulatory inspection. Through the regulatory inspections, this involves the inspections of organization by a regulatory authorities to assess compliance with the licensing regulation. Here we have to understand there are certain mandatory regulatory inspection requirements by the national standards, and there are certain optional requirements which are opted by the organization. For example, if in Pakistan we can say we are regulatory requirement in terms of the Punjab Healthcare Commission and the Sindh Healthcare Commission, and the opted standards, the opted accreditations are the WHO, the JCIA, the Canadian accreditation, and so forth and so forth. So these involve an inspection of the organization at a regular interval of the time to know the compliance standards and the services and the compliance of the services provision to the patient. And in other way around, we can know the outcome, they are measuring the outcome as well, so that they can guarantee, they can give you the assurance that the compliance standard has been fully met, partially met, or not met. So it has been described as the sustained and focused control exercise, which is the regulatory inspection by a public agency over activities which are valued by the community. So the standards against which the organization are inspected are often based on the minimal legal requirement or safety care for service users. How it will come and how the evidence-based practices they are measuring, this is some very vast subject we can discuss some other time. So here we will consider the survey of the consumer experiences, the second party. As healthcare delivery increasingly focuses on empowering services users through health education and increasing their understanding and awareness of the expected level of performance of the healthcare services, consumer surveys are increasingly being used as a mean of assessment. How we are assessment? Usually, we are conducting two types of the surveys: the patient satisfaction survey, which could be the inpatient satisfaction survey or the outpatient satisfaction surveys, and some specific surveys as well. So, by these surveys, we can assure, we can know the insightful of our customer, that what are the services we are providing, it's satisfactory to them, or how the experience was from the consumer side. So the benefit of this approach are that it monitors performance from the service user perspective and identified what is valued by service users. So a part of these two satisfaction surveys, there are several other surveys as well, including the donor satisfaction survey, the vendor satisfaction survey. By different departments, they are conducting their satisfaction surveys. Like for example, in case of the food department, they are doing their satisfaction surveys, and if they want to improve, they are taking feedback from their customer. So there are various ways to capture this, the patient experience, consumer experience, or customer experience. So the third party assessment, as I have just mentioned in the beginning of my talk, the third party assessment, it could be the optional way. Usually it's the optional way, like JCIA, WHO, Canadian, Australian accreditation. These are the third party assessment. They and often they are voluntary and usually combine internal assessment with the external audits. ISO is one of the very good example. It's very common in Pakistan too. So it includes certification against ISO standards, involves monitoring compliance with the quality system rather than hospital performance alone, and usually involve measuring aspect of the organization, such as laboratory systems. So peer review is a form of professional self-assessment, usually done for the purpose of gaining recognition as a training facility. It involves professional visiting from an external organization to peer review other professionals from their own discipline. So, as a third party assessment, accreditation involves measuring hospital performance through self assessment, external review by a multidisciplinary team, and a benchmarking with selected KPIs. So, we can say the accreditation is usually done for the purpose of organizational development rather than regulation. As I told you, there are two types of the accreditation. One is mandatory accreditation, which is meant by the government or by the state, and another one is optional, which is the third party assessment. So, how to develop this key performance indicators? KPIs are measure of performance based on the standards determined through evidence-based academic literature or through the consensus of experts when evidence is unavailable. There are certain areas in healthcare industry where evidences are not available. So, in quantitative term or in the qualitative term, here the consensus is made by with the help of the subject expert. So, according to the Joint Commission International Accreditation, KPIs are not intended to be direct measure of quality, but instead act as an alert to warn us for opportunities of improvement in the processes and outcome of service user care. So some are the very common KPIs in hospitals. We all are must aware of it. Are surgical site infection, hospital readmission rate, waiting times. These are the key performance indicators. Usually, organizations are taking or as an alert for the continuous improvement purpose. So, the performance indicators are methods used to assess performance. For example, in non-profit organization or in profit-seeking organizations, their intent is to enhance the profit. They want to know about earning per share, sorry, return on capital employed. This is the intent of the profitable, yeah, profit-seeking organization. Or in non-profit organization, usually they are looking for the exams grade. If the organization is a educational sector or the university or a teaching hospital, waiting time for hospital admission, healthcare services they are looking for in a non-profit organization, and condition of the road, a local government highway department. So these are the three main example of KPI. Like if a school or the college is there, their KPI must be the exams grade, how much A or A star their organization is achieved at the end of the year. So this is their performance or this is their success indicator. So in case of the healthcare services, waiting time for hospitals admission, this is a usual indicator they are using for assessing the health services. This is one of the indicator. So if we are looking for the government sector or the highway department or the operational sectors, they want to assess their success by with the help of the condition of the roads. So these are the example of the KPIs usually we are looking for and we are measuring too. So healthcare KPIs measure how successful your organization is when it comes to achieving those stated goals. So we have to develop the objectives, goals, or which must be the SMART goals. The KPI helps bring transparency and accountability because these are the quantifiable measures. So everything which is quantifiable, uh, it will lead you towards transparency and accountability, which lead to the better outcome and the better delivery of the care. So by promoting process of perfection, KPI offers a clear roadmap towards implementing quick improvement that can have a significant impact on quality of the care. Additionally, we can track financial metrics. By tracking a financial metrics, we can reduce cost, we can improve our budget, we can forecast our future predictions, and we can help ensure patient can pay for the care they receive with the fewer issues. So our main objective is to continuously evolve the process of improvement. Finally, creating a tangible and measurable KPI gives you a useful data visualization tool. In the beginning, if you remember, I told you that we cannot improve if we cannot measure. So these are the tangible, these are the measurable, quantifiable, tangible visualization tools which will help us to build a better understanding for the operation and on a more granular region. So which KPI should I use? We discuss about the quality, we discuss about the performance indicators, the usual types of indicator organizations are used. Here the question arises, which KPI should I use? So in defining the which KPI should I use, we have to understand that we have three main processes or three main domains, the structure. This is the Dona-Badin model of the beautiful and illustrated by Dona-Badin, the model of structure, process, and outcome. So in structure and process outcome, there are two different things, the generic and the specific. I told you in the beginning that we have to be focused on the measurable criteria. So generic and specific, they are focusing on the prevention, acute and chronic. Acute side, chronic illnesses, and the preventive side as well. So in this way we have to further subcategorize into, if you want to do the screening, the assessment and diagnostic KPIs, the interventional or treatment KPI, or the follow-up KPI. So before starting the question that which KPI should I choose, we have to choose whether we want to measure the structure KPI, we want to see the processes, or we want to go for the outcome KPI. So we have to be too specific KPI. Like for example, if you want to see the outcome of any disease treated in your hospital, so you will go for the outcome KPI. If you want to know the process, the readmission rate, this is the specific, and you will go for the process KPI. If you want to see the structure of any or structure or model of the organization, you will go for the structure KPI. So in this way, we have a generic KPI, the specific KPI. For example, the organizational level, we are usually monitoring the organizational KPI, which could be derived from the departmental KPIs as well. So in this way, if you want to see the acute side, the chronic side, or the preventive side, if you want to see the preventive diseases or preventive measures, so you have to achieve the preventive KPIs. So acute and chronic accordingly. So this is your organization. This is the stakeholder. This is you who is going to decide which key performances you are going to measure. At the organizational level, definitely you will go for those core KPIs who can help you in deciding the further strategies for the improvement, for not only in the medical side, the surgical side, the organizational level, infection control level, or at the financial side, so that your financial budget will be in your control. So this is the stakeholder or the department head or the organization head who will decide which KPIs they will choose to measure the performance or the success of the organization at the organizational level, and then those KPI which they are going to monitor at the departmental level. So there are certain KPIs which we are going to monitor at the personal level, the unit level, the department level, and then the organizational level. These are the usual trickle down effect of one KPI, and they must be aligned with the vision and mission of the organization too. So one of the most common and effective use of KPI is quantifying patient stay and experience at a hospital. We all know that one point in a time in our lives that we have an experience to visit a hospital, the local hospital or the international hospitals, and the time we spend over there is our experience as a visitor, experience as a patient, or experience as an employee of the organization. So we are going to measure several things, and the conversion of these experiences into a survey, and the result of the survey will be taken as an improvement purpose. This is another one KPI measure, which usually we are going to measure once we are deciding to see the customer satisfaction index. These KPIs usually we are monitoring the length of stays, how long patient must wait for the services if they are readmitted, average hospital stay, ER waiting time, hospital readmission time, and the emergency cost in order to make the cost benefit analysis. So these are the performance indicators we are usually monitoring in our organizations for the improvement, for the continuous improvement purpose. So in the beginning, I told you that after giving the concept of the quality and the performance indicator, how it relate with the quality and performance indicator for healthcare quality assessment. So the ability to monitor healthcare quality is essential in order to effectively measure performances, which can be done with the assistance of KPIs. KPIs facilitates the capture of the healthcare trends as a quantitative measure of a quality. Continuously, I'm emphasizing on the quantifiable, the quantitative measure, because with the help of this quantitative data, quantitative measure, we can drive an inference, we can drive a strong strategy of improvement, and they make an inference about the quality of care provided and indicate areas that requires further investigation. So, how performance indicator help an organization? We develop a consensus that there are few organizational KPIs, there are few departmental KPIs, there will be few KPIs at the individual level. How these will achieve vision strategy. So these KPI helps an organization to understand its performance level and set a realistic performance goal. How to set a realistic performance goal based on the evidence-based practices. From where this evidence came, the evidence came with the help of the data, the quantifiable measure, the data which are monitoring over the continuously, regularly over the period of time. This data at the end of the year or at the end of the quarter will, after the analyzation, it will help you to define your gaps, and it will help you to develop a strategy to fill those gaps. So by this way, the performance indicator helps aligning daily work to the organization's strategic goal, and not only aligning a strategic goal, it will also help in monitoring its progress on a real-time basis. There are certain dashboards which show you the real-time data, and so that you can each and every step or each and every deviation from the processes, you can take a strategic direction or strategic improvement decision for the improvement if required on an urgent or emergent basis. So by these indicators, they help an organization to understand its weaknesses and establish improvement priorities. With the help of this data, you can prioritize your matrix, you can prioritize your strategic plans. So by these indicators, they determine whether an improvement is being made or maintained with the help of the data, with the help of the evidence-based data or the fake data. How to develop a consensus, how to develop a gap analysis. It's another different topic which we can discuss some other time as well. So by these KPIs, they help benchmarking internal with the external, that for how we are benchmarking. Once we develop a data and we are monitoring our KPIs, first we are benchmarking ourselves with our peer departments, and then internally we are benchmarking two different departments among themselves, and then we can benchmark those departments with the external or international data benchmark as well. So these KPIs helps or identify if the staff are doing well and to help them if they are not doing so. I told you that the gap analysis, these are one of the way of doing the gap analysis, and we can fulfill those gaps on the basis of the evidence-based data, and it provides the basis for recognition a team and individual performances as well. And in this way we can nominate the patient champions as well, or safety champions as well. We can nominate patients as a safety champion. We can nominate employees as a safety champion. So these performance indicators help a lot in improving of the daily work matrix. So healthcare, how they can and what they can measure. Healthcare performance, their performance level at the institutional level. There are three different levels: performance level, performance dimensions, and the system components. These three are under the umbrella of healthcare performance. At the performance level, we are looking for the strategic performance, the tactical performance, and the operational performance, or the financial, which is also included in the operational performance. So the performance dimensions, which is basically the part of the quality dimensions, which are safety, effectiveness, efficient timelines, patient-centeredness, and the equity. They are the main domains of the quality. So by this way, the performance level are integrating each other, or they are making a very valid link between each other. The safety and the strategic plan, the effectiveness and efficiency with the strategic plans, the timeline of the operational and the strategic and tactical plans. So patient-centeredness is the key element or integral part of all these activities. So the system, once we comes on the system, so these can be integrated among the structure, process, and outcome. Where are the domains? So the safety domains or the quality domains are integrating with the system component and the performance component. So performance level, we have just I mentioned that we have a strategic which are focusing on the long term and the short term goals, and operational shows that the shorter time frames and the operational processes, and tactical use by the mind management to track performance. So the at the if we can look about the common dashboards which we are using for the strategic, tactical, analytical, operational level, the level of seniority. The strategic is the senior management, discrete, tactical, analytical is the middle management, and the operational junior management. And the times they are certain areas are the for the short term and certain are for the long term. They are the complex processes, but with the help of the performance level, the performance indicator, it is very evident that the gaps are very clear and transparent, and each and everybody from the senior management to the junior management, they will agree. They can identify their goal, and they can develop a strategy as per the requirement. So according to the Dona-Madin model, which are the structure, process, and outcome model, healthcare quality can be assessed using a three-part model based on the structure, process, and outcome of the healthcare system. Structure, as I've told you earlier, the organizational and physical characteristic where healthcare occur. Process, the care delivered, the diagnostic process, the treatment process, the surgical process, and what is done for the patient. An outcome, change in the status of the disease, change in the status of the patient population, what is expected to occur after a healthcare delivery. Its structure is the process outcome. So performance dimension, I told you these are the 8-9 performance dimension according to the Institute of Medicine 2001 guideline. So there are certain indicators. These are just for the example. It's not necessary that everybody can achieve or to obtain all these indicators. Like for example, the operation, we are usually monitoring the patient waiting time, average number of the patient room in use at one time, staff to patient ratio, bed or patient or bed or room turnover, communication between primary healthcare physician and the proceduralist and the patient. And financially, in the same way, we are dealing with the average insurance claim processes, processing time and the cost, and how to reduce with the help of these KPI. We can strategize the cost and how to improve or reduce our cost, and how we can give benefit to the reduction of the cost and the patient. So claim denial rate, we are for those organizations who are dealing with the insurance claims as well. So average treatment charges, permanent employee wages, these are the financial KPIs they are using for the improvement purpose. In the same way, if we can go for the emergency department with the first encounter of the patient, either in the emergency or in the OPD. So in emergency department, patient waiting time by process step, and it is evident that certain organizations who are working for the reduction of the waiting time must do some QI project over there to reduce in the waiting time, or to reduce the base step or the duplication step or non-value added step from the process in order to improve or reduce the patient waiting time at ER department. So the time between symptoms onset and the hospitalization, it's also emergency KPI. One of the biggest KPI which we are measuring is the door to balloon time for the cardiac patient. The number of the visitors, patient who leave without being seen, the Lama-Sama patients. These are the indicators which we are monitoring regularly at the emergency area. So there are certain KPIs which are related to the care, meaning the medication error, patient versus staff ratio, patient follow-up rates. These are the care-related KPIs. So in the same way, into their internal KPI, the communication-related KPI, the public, which are mentioned here, public health related to the immunization program of the children, educational program, and the number of the preterm birth. So we can, these are the KPI, as I just mentioned, that on the basis of the result of these KPI, we can strategize our improvement and we can improve our services. So this is all about for today's talk. Thank you very much.
Thank you. We do agree that we cannot improve if we cannot measure, and if we cannot measure once we cannot report. So, error reporting is one of the integral part for the improvement purpose. So, my next presenter is Dr. Abdul Wahab. He is going to talk about the error reporting tool for evidence-based process re-engineering. So, Dr. Abdul Wahab is currently he's working at Shifa International Hospital as a director quality and JCI accreditation lead as well. And he's working as eShifa Home Healthcare Services. He's also a program director of fellowship in healthcare quality and administration, chief information security officer, and member of a board of Shifa Foundation. He also serves as a director in secretariat of Khyber Pakhtunkhwa Policy Board. Dr. Abdul Wahab.
To look at this presentation, the structure would be I'll be discussing give you a brief account of magnitude of the problem, some ways to identify errors, and how to assign severity to these errors. Once severity is assigned, how do we conduct root cause analysis for certain events that have taken place? And then we'll look at also the analysis of trends. At times, certain small events are taking place frequently. So over time, we can see and review the database, and we can pick up some hints that tell us the need for root cause analysis, and which might be a trigger for, in turn, process re-engineering. And what are the various ways to conduct process re-engineering? We'll have a look at that as well. Overview of the presentation, I'll be discussing a brief about magnitude of the problem, identifying errors, what are the various tools that we can use to identify errors in healthcare, then what are the ways to assign severity for these errors, conducting root cause analysis. We'll also look at analysis of trends through structured databases, and finally we'll look at how to do process re-engineering based on these errors that are reported through various tools. If we look at magnitude of the problem, Institute of Medicine states 44,000 to 98,000 deaths take place in US hospitals alone from preventable medical errors. This was a study published in 1999 and was foundation of most of the quality journey there onwards. It really changed how people looked at medical errors, and really gave a foundation to work further towards enhancing and making safe and secure systems for the hospitals. If you compare this with plane crashes, if we convert these numbers to deaths by plane crashes, we will be requiring almost every third day another plane crash to meet something along those numbers. How safe we will consider airlines to be if we hear that every third day there will be a plane crash, and if that takes place, even then they don't reach number of deaths taking place from preventable medical errors. This graph tells various professions and various activities, and if you can see, the nuclear power plants, where people usually think that they are very unsafe, are among the safest, even safer than the European railways, whereas healthcare is the most unsafe or dangerous profession to be in. Their leading cause of death, various studies have been published. International data states every third person is, every 3% of the patients are getting adverse events. Number of deaths from preventable medical errors almost is comparable or double of the deaths caused by motor vehicle accidents, breast cancer, or AIDS. And if you combine the three numbers, even still they are less than the deaths caused by preventable medical errors. If we look at the financial burden, there are several figures, but if we sum it up, we can see every dollar spent on ambulatory medications, another dollar is spent to reverse the effects of these medications, and 17 to 29 billion is spent on preventable adverse events. So imagine this much amount we are spending on medical errors. So we know that the errors are a serious business, and a lot of things do take place. Reputation is at stake, and uh, of all, we don't want any of our loved ones to be the victims of patient or of this medical errors. So we want to make sure these systems are safe enough. So how we can identify errors, we'll be going into that and what to do with that. So there are basically two ways: incidents or trend analysis. Once incidents or trends are reviewed, they're identified, severity is assigned. If we look at the um, causes of these incidents, and we reach somewhere on the root cause, and once root cause is identified, we can think of going for process reengineering or just improvement initiatives based on the impact and requirements of that particular incident. And finally, the process reengineering may take place. So these are the various forms that organizations use. Maybe mobile-based, uh, any app can be used for these things. Different organizations use different tools, and one commonly used tool is paper-based, usually liked by uh, everyone because it's available everywhere, and you can use your pen and just write the details down. Uh, a bit of uh, handicap with this thing is sometimes people like to keep reporting a bit anonymous, and if you're using only the paper based reporting, people might feel handicapped in that. There are pros and cons of anonymous reporting, but I believe the reporting should be more of system targeted reporting. So in that case, people should feel their identity will be protected, and to whom the incident will be marked. What we usually do is we don't share the name of the person who made that incident. So that is one way of addressing the concerns of those who want to keep their identity anonymous. So trigger tools are basically either proactive or concurrent or retrospective review tools where based on certain specific triggers, the organization tends to identify events uh, or triggers which point to a certain event that might have taken place, and then one needs to work on those triggers if the actual event had taken place or it was just a false trigger. One common example can be sudden drop in hematocrit in a patient amount beyond 25%. So automatically this within a certain period of time or post-operative, so automatically the system will pick up that the patient had lost so much blood, and now what's the cause of that? Is it related to the procedure alone, or is there something else? So one needs to study such triggers. So IHI has worked extensively on these trigger tools, and they are internationally accepted, and they are for diverse situations which are listed here. You can go to IHI website and work on that. These are really amazing tools. This is how a trigger tool looks like. You can see, triggers as being T1 refrigeration of neurological condition and so forth. For these are different trigger tools, and this is one just example I'm showing here. And the other example that you can be having is basically these trigger tools. They came up from the IT side. If you look at SIEM solutions, what they do is they look at the activity being done by different users on the network, and then they tend to show you that something good has happened or bad has happened, and the severity might be whatever the case may be, and then there's a dashboard which tells you what to look for and where to put your focus on if something is serious, and then you can investigate further. You can look into the details of that particular event to dig out if there's a suspicious activity or it was just a false alarm. Likewise, other ways can be your proactive approaches, where you're looking at use of reversal agents. You're looking at number of readmissions, number of patients leaving against medical advice, mortality rates, length of survey, length of stay, surveillance, and so on and so forth. All those clinical indicators which predict outcome of the disease. You can have those as, you know, measures of uh, patient satisfaction and measures of good clinical judgment, producing good clinical results. Likewise, you can get reports from ministries. Different ministries have different regulations that require you to act in a certain way. They have their own regulations. Then there are regulatory authorities. Islamabad Health Regulatory Authority is one common example for, organizations that are complying to the standards in federal capital. And then likewise, Punjab Healthcare Commission, KPs, and all of them, they are having their own standards, and organizations are required to comply to these. And whenever these organizations they visit or audit certain facilities, they will have their own observations. And this is another way to identify deficiencies in your systems or errors in your systems. One should take these reports as challenges and fix them at the earliest, because uh, being external eyes, they can always add value to our system, and they can always give us different perspective on how to go about things. We might be looking at the things in a different way, but they entirely have a different perspective, having seen so many different organizations as auditors. uh, Different organizations also comply to Joint Commission International Standards, then WHO, ISO, all these regulatory authorities. If you are a teaching institution, you'll be getting some reports where you can identify some areas for improvement from CPSP visits or things along those lines. So feedback surveys, they are another way to assess our performance, and at the same time patient tells us, or the customers, they tell us really good input about our systems and how they feel, because all of the patient care or the hospital services, healthcare services, whatever you call it, and whatever the function of your organization is is supposed to be centered around the patient and satisfaction of the patient, providing quality care to the patient. And what can be a better way to judge your uh, delivery of services than to get patient feedback? These days, patients are really educated and they provide very valuable feedback. Uh, if you take their feedback and just focus on the improvement areas that they have identified, and the problems that bug them, that is one really good way to go about when you're designing new systems. So for example, what we are doing right now is, at the screen, if you can see, the service was great. These are the four common words that we got from the patients when they were inputting their data. And this is what AI told us, that these are the most four common words given as feedback from the patients. Some patients had complaints about food, some patients had complained about. So based on those inputs, we always direct our efforts to minimize deficiencies of, or shortcomings of delivery of service in those areas. So now we were looking at, sorry, different errors can be reported. We already saw the reporting through incidents and different reports. Now we'll be assigning severity to these incidents. Different organizations use different tools. This is the one we use as Shifa, and this tells us basically how much severe that event has, that the event that has taken place, how much severe it is. Uh, Basically, is it a clinical or it's a corporate consequences? Clinical, where patient had some injury, or patient might have harm or unanticipated death. So if it is category wise seen, so serious most category for patients where there is a permanent or major loss of function, unanticipated death, or a sentinel event that, as per definition of JCI, there are several categories of events. If they take place, they are considered sentinel events. Likewise, major, moderate, minor, and minimum. Uh, if you look at the corporate consequences, something related to staff, visitors, services, financials, and environmental factors. Then after going through the consequence analysis table, we go at the likelihood, how common this thing can happen. Again, if you look at the past, so you can assign frequency of that event taking place. It is likely or unlikely, and there has to be a rational scoring system. So once these two steps take place, then you can assign based on the severity and the consequence analysis, either the event to be S1, 2, 3, or 4, S1 being the most serious event, and S4 being the least serious of event. The other thing that we said earlier, another way to identify your errors is analysis of trends. If you are keeping track of your data and there's an established database for various indicators, errors, all those things, you can use different tools. You can use different mechanisms to that tell you that how your organization, what are the trends of errors taking place in your organization. So if you look at your this graph, this tells you how over a period of time, number of different events that were reported. If this can tell you if reporting is appropriate, certain dips are there, probably due to COVID, probably due to other factors, and then you can see how many of them are open, how many of them are closed, what are different patient areas that they are addressing, and according to severity and so on and so forth, you can have different analysis. Investigating an error is the next logical step in this chain. So when we're investigating any error, we need to keep a few things in our mind, that the one who has reported an incident, uh, his identity should be protected as much as possible to ensure that the culture for reporting is encouraged and people feel safe when reporting any incident. The other important factor, or the fact, this was Deming's statement, that 85% of the errors are a result of system failures, while only 15% of the errors they come from human intervention, although the system existed. So this is a known fact, and one should keep such things in mind. The other thing is that the one who has committed a mistake, he is a human being, and there are social and psychological problems that follow any medical error, because it's on a patient, and patient might have been harmed, and the one who was involved in this thing definitely will have some sort of guilt or remorse to what has happened, and we need to be supportive and provide ways. So we don't want healthcare staff psychologically burnt out, or you know leaving the profession because of their guilts and these things. So we need to ensure when such things happen, we take care of this side as well. So whenever a sentinel event is reported, it has to be informed at the earliest to the leadership, and any critical event that we identify based on our consequence analysis and severity metrics, and once it is identified, if root cause analysis is warranted, it has to be initiated and completed within 45 days, and leadership should ensure all the relevant resources for such analysis is available, and the team that works on it is appropriately organized, and those who are close to the process, they work with the core team and find the real problems uh, behind the incident. So one can start with drawing flowchart from point A to point Z, wherever for all the processes that are involved in outcomes that has happened, and then if there was any failure of any process, any step that has resulted in that particular event, that can be highlighted. Likewise, some people use fishbone diagram or Ishihara chart. This chart helps us, to look at different aspects of the system, be it equipment, process, people, and all those things. Once this is done, you have identified the things, but you need to make sure that these things are actually the root cause. I love this statement by Benjamin Franklin, who says, "A little neglect may breed great mischief. For want of a nail, the shoe was lost. For want of a shoe, the horse was lost. For want of a horse, the battle was lost. And for want of a battle, the war was lost." So if somebody asked why the war was lost, you will say because the battle was lost, and why the battle was lost because the horse was lost, and so on and so forth. And at the end, we'll find there was no nail, and why there was no nail, because somebody stole it. So just because one person stole a nail, we lost the whole war. So that's how you reach, the root cause. Beside the usual things, the evidence, you have to study your all medical records pertaining to that particular case. If it is a clinical medical error, you have to conduct interviews, you have to review your policies, procedures, and all other relevant evidence before drawing conclusions. And then you have to bring that all of those things on document form. You have to identify initially all the reasons, and then document, so everybody is informed in writing, and the leadership can have a structured report which tells how the whole system was reviewed and what were the findings in different areas. So when we go to the process reengineering part, all the problems that are reported, or all the events that are reported, are not going to be requiring a process reengineering approach. Most of them would be just addressed by improvement initiatives. So we usually do process engineering when there's a high risk, high cost activity, and it is really we have tried already everything but couldn't fix something. So now we need to come up with some way to, really restructure the whole process and whole system. So at end of the day, the people that are working with it, they have another dimension to work with. Before going for this thing, one needs to ensure that the culture is conducive, and you can start with cultural assessment. And the best way to define a culture for me is the worst behavior that is tolerated uh, by any organization. That defines the culture of the organization. We can look at our organizations and we can see what worst culture or what worst behavior is tolerated. Another way, some more scientific, AHRQ has developed culture of safety surveys, and they help you assess how the staff feel about the culture of safety in their organization. Once you have assessed your culture, you also have an idea of who the stakeholders are for any of the improvement project that you're planning to take, and you can have stakeholder management metrics. You can apply that, and you can use such matrices to address the needs of certain people and identify strategies that you are going to use to address their concerns over time. uh, Once team is formed, once stakeholders are engaged, then we need to identify the objectives of our project. We need to take it as a project whenever we are starting to re-engineer a system or a process as a whole. And at this time, we need to identify at the end of this whole activity exercise, what do we think will be our outcomes. So, for example, if you're restructuring your patient waiting times, then your waiting time would be a very important factor in this thing for patients who are coming in with appointments, and those patients who are coming without appointments in the OPD. What would be the average waiting time compared to what is current right now? The other thing is we need to identify who will do it, and uh, what will be the methodology and when it will be done. Just who and what is the simple methodology we use. Objectives, as always, should be smart. Then we already know what the current process is, and we need to revise with the new team and those who are close to the process what can be the easiest way to get the outcomes. And if there's a restructuring of the processes required, as we agreed in this case, we are going to invest in restructuring. And now we define and make more simpler diagram, much simpler diagram, which where the patient flow is minimum, where the patient movement is minimum between different stations, and then ultimately patients, they come in and move out earlier, compared to the previous system where 100 steps were involved. Now we have like 30 steps. And during this thing, what's most important is you have to ensure monitoring during the implementation phase, and the outcomes. They have to be continuously monitored. Whenever there's a change, cultural aspects are to be addressed. Uh, People are reluctant to change, and people are going to have some reservations. And as a project lead, you have this responsibility to ensure you are the leader of the organization, that whenever the cultural changes are taking place, you address people's concerns, and whatever the outcomes are, you openly discuss with the organization's stakeholders and external stakeholders. The communication metrics should be quite open, and you have to define what communication needs to take place with what kind of stakeholders through communication metrics. We can also use certain tools like Gantt chart that lists down all the activities that are required for such things. And once the activities take place, we need to ensure that performance of each of those involved in this thing is reflected using objective measures. So basically, what we said earlier as indicators for certain things, now we are looking those indicators as performance of the individuals. So this will be reflected in their performance as well. And this is one way of ensuring accountability. This is my last slide, and what my focus here is that all of the process engineering approaches and whatever you do, you need to be advocate at fair and just culture. And if you are advocate for fair and just culture, everything and every individual in the organization will automatically start supporting you in this direction. Because once the culture is established and the people are comfortable in reporting such things, they will be very much supportive in making or bringing about the change that you're looking for as a leader. Thank you very much. And if there are any questions, I'm available.
Thank you very much, Dr. Abdul Wahab, and special thanks for you. I know that you are not feeling well, despite of your condition. You made it, Alhamdulillah. Thank you very much, and we all are praying for your quick and complete recovery soon, inshallah. So yes, we do agree that error reporting is one of the integral part of the improvement. If like we agree that we cannot improve what we cannot measure, and for the measurement of the occurrence, we have to report. If we will not report in a we will not report we will not able to analyze our data and make a strategy, evidence based strategy. So with this we have another presentation, and this is my honor to invite one of my mentor, one of my teacher, Professor Asaf-Alasaf, which is which is the professor at the University of Oklahoma and executive director of American Institute of Healthcare Quality. He has 40 years plus experience of progressive healthcare experience with the clinical and managerial role, including special expertise in health system strengthening, healthcare quality, and health service administration. He has been serving as an international healthcare consultant for WHO, USAID, and the World Bank and UNDP, and to several international government agencies. Uh, the topic will be implementation of CQI processes, a multidisciplinary approach. Welcome to Professor Asaf Al-Asaf.
Thank you. I hope that you can hear me and see me well. If not, I'll get a response. Anyway, thank you very much for inviting me. Thank you for being here. I will be talking about the CQI processes or CQI models. However, before we start the different models or share with you the different models, I'm going to share with you the slides. So let me start with that. I hope that you can see my presentation, right? If anyway, if you don't see my presentation, please let me know, and I'll see what's the thing. Okay, so what before we start the different.
Dr. Asaf, we can
Yes.
no slide share.
Oh,
We
no
cannot
slides.
see your no. Yes.
Okay, let me see what's the deal. It is there's share, and there
Yes, can you please?
is slides, and it says you have no slides, so I don't know why. Um, uh,
Slideshow. Can you please
says
press it?
yeah, you have says your computer upload file. No slide share. Do I need to upload it or just share it? Because
No, you
here it
can
says
directly share as well.
yeah. I don't know why it's not showing. Um, let me see. Sorry, guys.
And then go to the slideshow and press it,
Yes, I did, and it's
and then
still.
close it and do it again.
Yeah, I did that. I don't know why. Okay, let me do it again.
Are you sharing your screen? Can you please press screen sharing?
Yeah, I'm gonna yes, share screen and let me start with the presentation again. And here is. Do you see it now?
Not yet.
Well, that's that's the best. That I mean, I shared the screen, and here's my slides. I can see my slides, and I don't know why it's not doing it. It says, okay.
म्यूट उनकी तरफ से हुआ हुआ है. Dr. Asaf. Dr. Asaf, we cannot hear you. No voice. Dr. Asaf, we cannot hear you. Can you please unmute your mic?
Okay, can you hear me now? Okay. Yes. So still I have problem with the sharing of the screen. Sharing. I don't know why it's not sharing it. Dr. Lubna, I don't know what to do. It's not sharing the screen for some reason. The screen for some reason. I don't know. There is some problems.
Okay, you can start even without presentation.
Yeah. So let's. I think we can. With no presentation, with no slides, it will be very difficult. So I would suggest that we. I will just talk in general, and maybe later on we can share the screen later on.
Sure.
Okay. What I wanted to show you is I wanted to show you some of the different approaches to performance improvement. And I wanted, before we start that, I wanted to share with you some of the goals that have been identified by the IHI, the Institute for Healthcare Improvement. And they have identified 7 goals towards performance improvement, or towards the continuous quality improvement. And they come up with the first goal, which is says achieve zero harm to all patients. Well, achieving zero harm to all patients, it's easy said than done. Zero harm, can we really achieve zero harm? That's a question. In the US, we have events that are harmful to a staff or a patient or a visitor it reaches up to 5 million a year or even more. I'm sure other countries have the same issue. So how can we reach zero harm? In fact, some people are saying that they will never reach zero harm because some of our interventions to the patients cause harm to the patient. So how can we reach zero harm? I think it's the issue here is not necessarily zero harm that is unexpected harm, but it is more a zero harm that is organized harm or expected harm. For example, a surgeon, when a surgeon performs an operation, he causes harm to a patient. When an endoscopist introduces an endoscopy to a patient, he causes some harm to the patient. So which harm is worse than the other? And that's what really one could identify and say. Some harms are positive harms, more or less, and some harms are negative harms, and we will try to minimize or reach zero negative harms. The second goal, they say that we ensure a safe environment. And ensuring a safe environment, when we talk about safe environment, we're talking about a safe environment not only to the patient, but the family, the staff, the visitors, throughout the healthcare organization's activities. And what we mean by a safe environment, it includes everything from the environmental safety, the whole issue of the general safety, general security. It includes the safety of the water that they use, safety of the electricity, safety of everything. So it is reaching a safe environment that it includes the structural safety in addition to the clinical safety. Number 3 says deliver high level, high value care. And when we talk about high value, what does that mean? High value. High value, it is a component of three factors. It involves the quality of care, it involves the cost of care, and it involves the outcome of care. So when we say we have reached a high value care, all of those components have to be there. We need to provide a high care services or high care processes that are not expensive, that are affordable to the patient, and get a positive outcome to the patient and hopefully to the staff as well. The fourth goal that they mention is to provide an optimal patient and family experience. And in here, they're talking about the always events. I'm sure you're all familiar with the Sentinel events, or the events that are major events that causes harm to a patient or a staff. A Sentinel event, and most of these Sentinel events are preventable events, and therefore the U.S. and UK have identified a list of about 30 such events. They call them never events. It means those events should never occur in a healthcare institution or in a healthcare setting. So having said that, what is the opposite to that? We are familiar with the negative, with the never events. Well, what about the always events? What about the events that should occur on a regular basis? If you come to an organization, you come to a reception, and you come and say, I am here to see a doctor, Dr. X, whatever. An always event should be a smiling face. An always event should be a welcoming gesture. An always event should be a respect to that individual. An always event is a clean environment. An always event is a low noise environment, and so on. So the always events, even though we don't recognize them, but they should be there always. And every healthcare user should have access to those always events and expect always events at all times. So we should concentrate not only on the negative events or the never events, but also to accentuate and increase the always events and make sure that these always events always happen, so that the family and the patient have an optimal experience whenever they access our healthcare system. Number 5 says, understand and adopt reliability as an operating system in healthcare. And when we talk about reliability, it means that reproducibility or repeatability. It means that if I come to this organization today and receive healthcare, I would like to receive a similar quality care if I come the next day, or I come the next month, or if I come the next year. So reliability, it means that we continue to deliver the quality services that we aspire, and we have to achieve that in a repeatable, reliable manner. So reliability is an important aspect of healthcare. There is an article that talks about highly reliable organizations, and they have identified several organizations throughout the world that they call them high reliable organizations. And highly reliable organizations are organizations that expect the negatives before they occur. They are always reliably achieving positive outcomes. They are always reliably achieving positive processes. So reliability is a repeatable effort and repeatable activity within these organizations. Number 6 says design and implement healthcare work processes to reflect evidence-based best practices. And we're talking about best practices. We're talking about practices that are well researched, well referenced, and well used throughout the region or the world. So implementing clinical practice guidelines, evidence-based clinical practice guidelines, implementing clinical protocols, critical pathways that are well known, well established, well researched. That's a goal. But not only implementing those is a goal, but I think it is implementing those, monitoring our compliance to those best practices, and making sure and enforcing the care processes to coincide with these best practices. Number 7, it says influence and reinforce behavior accountability of individuals, teams, and organizations. And here we're talking about the accountability of these individuals, accountability of the system, accountability of the people that provide the care process. Accountability is not only responsibility, but it's also have the authority to make changes that are best, that has the best outcomes to the organization and to the patient. A person who is accountable to their activities means a person who is responsible, a person who takes ownership of their processes, and a person who stands behind the services and the processes that he or she provides, and defend it, and hopefully that it is a positive outcome. But also from the organization standpoint, there should be a system in place where those people should be held accountable if there is something goes wrong, and also they should be held accountable for the positives and the negative of the organization. So having said that, what are some of the Cqi performance models that are out there, and how can these be identified? Unfortunately, I couldn't share with you the slides that I have, but I have identified, I would say, four or five major models towards performance improvement. And the first model, I call it the 10-step model. And the 10-step model, it is the quality cycle that we have used throughout the world with help of USAID. And the 10-step model is a model that identifies what is it that we need to improve, whether it is through monitoring of processes, or through incidence reports, or through observations, whatever. So once we identify that, then we plan what needs to be done. We set the standards and set the desirable outcomes. Then we communicate those desirable outcomes. We identify a team to see where we're at compared to where we are now compared to the desired outcome. We identify what caused this problem to occur, what caused this process to be lagging. We understand that process, and then we identify solutions or implementations. We implement those solutions or interventions and remeasure the system. That's they call it a 10-step model, and that has been applied throughout different organizations over the years. The other model is, I'm sure all you are familiar with it, is the IHI model, the Institute for Healthcare Improvement model, which is the Pdsa, Plan, Do, Study, Act. And the Pdsa is a model that has been used since the 90s. And it starts with first the aim, identifying the aim. What are we trying to accomplish? The measures. How will we know that a change is an improvement? So we have to measure that. We also look at the changes and what changes can we make that will result in improvement. And then we start the plan, do, study, act. And the plan, we are planning the performance, identifying the priorities for performance. We provide or implement the improvement, whatever interventions. We study the implementation. We identify whether we are on the right track or not. And if we are on the right track, we act on it. We monitor, implement, sustain. And that is the model that is used by the IHI. The next model is the Focus Pdca. And the Focus Pdca, if I recall, it is a model that was introduced by HCA, Hospital Corporation of America. And the Focus Pdca is the focus is an acronym for find an opportunity, organize a team, clarify the process, understand the problem, select a solution, and then do the plan, do, check, act, which is somewhat similar to the one by IHI. So in this case, you identify an opportunity to improve, you organize that team, and then you clarify what is the opportunity and what is the background about it. Understand what are the obstacles, the issues that needs to be improved. You identify solutions or interventions, then you plan the interventions implement the interventions, then check whether the intervention worked or not, and if it worked, you sustain the intervention. The next model is, a lot of people are very familiar with it, is the Six Sigma model. And the Six Sigma model is, we call it the DMAIC model, which is the define, measure, analyze, improve, and control model. And in this case, it is based on the Six Sigma concept. With the Six Sigma concept, it means we want to minimize or eliminate, or at least make the errors so rare that it is up. We will achieve no more than 3.4 errors per million. So that's the Six Sigma model. The Six Sigma model, of course, I'm not going to go through the different steps of the Six Sigma and what is the background and so on. But Six Sigma, it is really a concept to minimize errors, to improve processes, to perfect system outcomes, and they're using a 5-step concept, which is define the opportunity for improvement, measure where you're at and where you want to achieve, analyze what's going on, then identify interventions to improve, and then you control it by sustaining the gain. The last model that I want to share with you is the lean model, the lean management model. And the lean management model is basically is trying to achieve 3 outcomes: reduce or eliminate waste, reduce and eliminate reworks, reduce and eliminate duplications. These 3: waste, duplication, and rework. So how do they do that? The lean is a concept. I'm not going to go through the details of it, but they have certain concepts, certain methods to go after to achieve those goals. So some of them, they use also the Pdca or Pdsa. They also used what they call the 7 waste. 7 waste, and 7 wastes are identified as the defects, the overproductions, the waiting, the non-utilized staff talents, the transportation issues, the motion, the inventory, the extra processing, all of that. They also implement the other model. It's called the 5S model, and the 5S is I think it's a Chinese model, where a simple method for creating clean, safe, orderly, high performance work environment. So you do sort, you set in order, you shine, you standardize, you sustain, and also all of that through safety. You also standardize work. That's another method. You can use what the lean model uses, the Pokeyoki. Pokeyoki is the error proofing of different activities. Or you do the visual management, where you organize your activities and you organize your inventory based on visual organization. Or you can use Kaizen, which is a small events that cause improvement on a cumulative basis, and that is a continuous process of improvement. So that's another thing. And then the other issue is problem solving, identifying problems and solving problems, even if those problems are small but consistent. So these are some of the models that I wanted to share with you. Unfortunately, I couldn't share with you visually those models, but these are the different models, and almost all of them, as you heard, were based on teamwork and interdisciplinarity, and that's what is going on. And hopefully, your organizations have adopted one of those models to implement and pursue. Again, thank you very much. I'm so sorry for the technical issues, but I hope that by the end of the conference, I will send those slides to Dr. Lubna to share with you at a later stage. Again, thank you for the opportunity, and I appreciate this activity. Thank you.
Thank you very much, Asaf. It's really a wonderful and knowledgeable presentation. Unfortunately, we couldn't able to see your presentations, but laterly we can share with our participant. With this, our session is going to end. Thank you very much, all the participants and all the speakers, for your valuable input. Thank you very much.